So welcome to this session on training the future endoscopist. We had some great discussion earlier on about how to do colonoscopy and how to do it better. But now what we really want to do is show another one of those beautiful case vignettes, and this time from another one from Dr. Roland Valori and Dr. John Anderson about how to progress in the sigmoid. And I think that this really is another example of how with use of the scope guide, with use of didactic instruction, with also dynamic feedback, you really can get your trainee through difficult situations. And in this case, the trainee doesn't make it, but it's still a very useful exercise to watch, and then we'll deconstruct it afterwards with either John or Roland. Thanks very much. We'll go to the video.
If you see this position, Hannah's got the scope. This is not a good position to help you rotate the scope. So you want it as straight as possible. And if you need to apply clockwise torque, just pop your hand under there and go like that. Okay?
Yeah.
And try and keep a nice C on the outside. You'll be able to torque the scope with your fingertips. Does that feel a bit better?
Much easier.
Yes, yes. Okay. When you start talking, you withdraw. You don't stop withdrawing, but you take the speed off, and then you put more and more torque on. And then, with an example like this, you have to put a lot of torque on very quickly, otherwise it won't come round. So when you get a bit more experience, what will happen is you won't do the planning. I can predict this. Okay, you'll just and you'll just do it. And okay, but if you do a manoeuvre and it fails, there should be an alarm bell ring in your head saying, "Oh, hang on a moment. I just need to think about this. I don't want to fail a second time. So now I need to think about exactly what I'm going to do at each stage to get it first time." Okay.
Mm-hmm.
So you have to modify your technique, and I don't want to go into too many details about that because that is a technical thing. I want to concentrate a little bit on the training, and what you saw at the end there was what we call a feedback, a hot feedback. So immediately after the procedure, we sit down with the trainee and we tend to go through the procedure. And if you do this with your trainees, I want you to recognize something. If you allow the trainee simply to talk, they tend to describe what happened. They just describe it. And you were in the room, so it's like having someone replaying what you've already seen. And what you really need to do, and what Roland did with some aplomb, was he forced the trainee to reflect on what had happened. And if you want to get into the habit of doing this well, you simply ask the trainee, why did this happen? Why did you feel like that? Why could you not do this?
And you will see throughout my slides that I'm always citing this paper by ESG. It's a very nice paper from last year where evidence is shown clearly. You really know what to do for almost all endoscopic management. So they state that in a diagnosis of GPHS, you have to start performing upper GI endoscopy from the age of 18 and a bit later in BMPR patients. What about people with the Poitz-Jeghers syndrome? Again, remember we started by saying that you need 2 hamartomatous polyps to suspect the polyposis syndrome. Well, if you see Poitz-Jeghers patients, if you have a patient with the typical mucocutaneous pigmentation, the picture that you see here, then you don't really need the 2 polyps. If you only find 1 polyp, then you already have to think about Poitz-Jeghers. So this one can be confirmed genetically as well. And here you need to survey even more. So these patients are at risk for small bowel polyps. It's usually the way we get to know them. So it is suggested more and more to follow these patients either by MRI angiography or video capsule. You need gastric surveillance, but you also need surveillance from the pancreas. So the one thing that is not cited in the statement paper of ESGA is the pancreatic surveillance in the Poitz-Jeghers patients, and that's something we as gastroenterologists also have to be aware of. So these patients are really at high-risk patients for developing pancreatic cancer. We don't have a very surveillance program as strict, as good as colonic screening programs. but it is suggested that these patients need MRI and EUS like the other high-risk patients for pancreatic cancer from the age of 30. They also have a risk of developing breast cancer, endometrial cancer, and ovarian, so you need to be sure to make sure that these people are also surveyed by your colleagues. So again, the paper is very clear about when to start and surveillance and what the intervals are that you should use, but they forget to mention the pancreatic surveillance for the Poitz-Jeghers syndrome. Conclusions, I think I can cite an evidence-based conclusion made by the ESGE that says that you need to handle these patients in endoscopic units that are used to treating these patients and that check for compliance and for outcome measures. But I think you have to couple yourself to other people like me, for instance, that know the overall management of these patients. You need dedicated multidisciplinary consultations, and probably it's good to have dedicated registers as well to get answers to unsolved issues, such as the real intervals for pancreatic surveillance in Poitz-Jeghers, upper GI management in FAP, and what to use as chemoprevention.